All right. Well, thank you again to everybody who has joined. My name is Carrie Frank. I am the Vice President of Communication and Marketing, and I will be helping facilitate our presentation today. Thank you again for being here. We're excited about our topic for Data to Drive Decisions today. We're talking about curbing prescription drug costs in Colorado, and we have a great lineup of presenters with us today. I'll introduce them here in just a second. First, just to run through the agenda, we will be talking about prescription drug costs and drug rebates in Colorado, just kind of to set the level playing field of what's going on. And then to address the issues that we're seeing with prescription drug costs, there is a new prescription drug affordability review board. So we have folks on the line who are going to be talking to us about what that means and what the overview of what we call PDAB affectionately, and the charge of the board and committee that has been established. We'll have time for questions and feedback from all of you who have joined today. And then we also have just some housekeeping items. The session is being recorded, so you'll be able to see this again later. Or if you want to share with colleagues that didn't get to participate, it will be recorded and available on our website. And then throughout the presentation today, all of you are muted, but please feel free to type in questions via the chat box, and you don't have to save them towards the end when we are doing official Q&A, but if there are some things that we want to jump in and ask as we go, that'd be great. Some of them we might hold till the end, but feel free to type in at any point in time any questions that you might have. I'm excited to be joined today by my colleague Civic. Kristin Paulson is our Chief Operating Officer. She's going to be going over the kind of the lay of the land of what we're seeing with prescription drugs in terms of the claims data that we collect. And then Lila Cummings is with us as well. She is the DOI Prescription Drug Affordability Board Director. And we're excited to have her as well as her colleague, Callie Shelton, who is a policy analyst for the Prescription Drug Affordability Board. And they're both based out of the Division of Insurance here in Colorado. So thank you to all three of you for being here. I'm just going to go over really quickly our mission, just a little background on Civic in case some of you who are joining haven't encountered us before. We're a nonprofit, independent, objective organization, and we really strive to empower individuals, communities, and organizations through providing support services and healthcare information to advance the triple aim, and that's better health, better care, and lower cost. And we serve a variety of stakeholders with the consumers right in the middle. So we serve hospitals, clinicians, provider groups, nonprofits, researchers, state agencies like we have on the phone today, employers who are providing healthcare for their employees, and health plans. And again, everything that we do is really focused on that improving the lives of consumers in Colorado and making them healthier and making healthcare more affordable. So today, the beginning part of our presentation is going to be talking about data that we are seeing in the all-payer claims database in Colorado. Just some background, if you're unfamiliar, we collect claims from commercial insurers, Medicaid, Medicare Advantage, and Medicare fee-for-service. It represents the large majority of lives in the state. We think around 65 to 70% of all Coloradans. We have lots and lots of claims in there, getting close to 800 million. So we're very proud of the mass amounts of data that we collect and the things that we do with that to turn that into actionable information. And the way that we do that is we inform through both public APCD data. So there's a lot of information on our website at civic.org in the space of prescription drugs, as well as cost and quality and utilization. And then we also provide non-public data as well to, again, all of those stakeholders I mentioned before. And those are through data sets and reports that are specific projects that people are looking at triple aim objectives. So trying to, again, improve healthcare and lower costs. So I'm going to turn it over to Kristin to kind of give you some background about prescription drugs in Colorado. Go ahead, Kristin.
Thanks, Carrie, and welcome everyone. So I'm going to be talking a little bit about sort of the context that drove a lot of what became the Prescription Drug Affordability Bill, and just give you some background on prescription drug and rebates as we see them here in Colorado. So as you can see on this slide, in 2019, $4 billion in Colorado alone was spent on prescription drugs. That's 20% of the total healthcare spend overall. And this is a trend that is very similar to the national trends. We're seeing not only huge amounts of money spent on prescription drugs, but that percent of overall healthcare spend is increasing over time. Next slide. So as you can see here, this is just an example of the rate of increase we're seeing in different parts of healthcare that contribute to what we see as the overall cost of care. So for 2013 to 2019 across all payers, the largest increase in costs happened in the pharmaceutical area. So we are seeing an 87% increase in the cost of pharmaceutical drugs from 2013 to 2019. That's contributing to an overall 32% cost of healthcare, and that's total. That's not just the consumer portion, that's the total amount paid by insurers and the patient. But we are seeing an enormous part of that increase is driven by pharmacy costs. Next slide. So here is a lovely little terrifying graph that looks at the cost of care for pharmaceutical costs only per patient per year. And this is for Colorado specifically. So this is graphing the amount of money total. So this is both the insurance company and the individual person. The average person paid from 2013 to 2019. So you'll see that those costs have almost doubled in those years. We're looking at 6-7 years, and we're looking at doubling of costs of pharmaceuticals. So this is a concerning trend that impacts not only the insurers, but also the out-of-pocket costs for patients. And I will say that this trend is across the country. If anything, Colorado is a little bit lower than some of the other places in the country, but this trend is actually, we're seeing this everywhere. Can we go to the next slide? One of the items that we are also seeing, and we're seeing this in a number of different areas, I'm sure many of you are actually have a background looking at discrepancies between urban and rural healthcare. There are issues with access, but we're also seeing significant issues with cost. As you see in this graph, so rural costs are represented in green and urban costs are represented in blue. So the average the average per person per year spend for pharmacy for urban areas was, I don't want to downplay the fact that it jumped from $900 to $1,700 in those years, but you'll notice that rural costs jumped almost $900, and we're sitting higher than urban to begin with. So the folks who are living in the rural counties across our state are carrying an additional portion of this burden and are being hit harder with the ongoing increases in prescription drug costs across the board. You know, the next slide? Oh, thanks. So I know there's a lot of publicity nationwide when we talk about the cost of specialty drugs. It's one sort of category of overall prescription drug spending. So the categories we tend to think in are generic drugs, brand name drugs, and then these specialty drugs that tend to be very, very high cost. You can see in these two graphs, looking at both the volume, so the number of prescriptions we're seeing, and then the spending for that volume. So we're looking at specialty drugs, which are 1% of the total number of prescriptions prescribed in the state of Colorado, account for just shy of 40% of the prescription drug costs. Again, this is a trend we're seeing across the country, but the folks who happen to fall into those who need that 1% of prescription drugs are carrying a huge portion of the financial burden associated with pharmacy. Next one, thank you. So this has got a lot of information on it, so we'll walk through this in a few minutes here. So if you look at the graph or the image on the right, this is a very simplified version of the drug supply chain and how dollars and rebates go back and forth. I have to say this is one of the more complicated aspects of our already complicated healthcare system. It can be very challenging for folks to understand sort of how those dollars get exchanged and where they get exchanged. if they're not part of this chain of supply themselves. So talking about drug rebates. So drug manufacturers set the prices, and then they sell drugs to wholesalers, who then sell them to retail outlets. So a rebate is a return of part of the price of the drug by the buyer back to the seller. So this is typically negotiated between the seller and a payer, or the insurer. And the payer here is either the insurer themselves, the insurance company, or excuse me, a pharmacy benefit manager, or a third party that an insurer contracts with to manage their pharmaceutical benefits associated with their plans. So these rebates can help reduce the health plan payments, but they may also incentivize the use of higher cost brand and specialty drugs when there may be generic alternatives that would be more cost effective, but would not be associated with as high a rebate or as high dollar amounts. The concern a lot of individuals have, and I will say this is a concern that is shared by the state of Colorado, and one of the reasons why the investigations and the exploration that created within the pharmacy prescription drug, I can't remember this, PDAB, prescription drug affordability bill. I'm having problems with my acronyms. Sorry, everyone. That issue of what happens to the rebates was a primary concern when this bill was put together. So the rebates go back to the insurer, and whether or not that impacts what the actual insured patient pays is up to the insurer themselves. So there's very little insight in what happens to those dollars and how they may or may not impact the out-of-pocket costs for a patient. Can we go to the next slide, please? So this is an example of what I was just talking about. So we know in 2019, on average, health insurers received approximately 27% back in the form of rebates back to them. So we're looking at, you can see the rather large chunk of change sitting there. Commercial plans specifically received approximately 15% back in the form of rebates. So we have discrepancies in rebates between public and private plans, and I will say there's also significant variation within the commercial plans themselves. So for public plans like Medicare or Medicaid, those dollars are used to reduce the cost of providing healthcare services. So there is, because they're public plans, more visibility into what happens to those rebated dollars than there is necessarily with the commercial plans. Can we go to the next slide? So here we can say sort of the trend in rebates. So if you look at rebates as a total percentage of pharmacy spending for both brand and specialty drugs, here on this graph, brand name is in blue, specialty is in green. You'll see a trend towards increasing overall drug rebate percentages, going from about 22% to almost 24% for brand name drugs, and jumping from just over 10% to over 13% for specialty drugs in just 3 years. And when we're talking about the billions of dollars that we saw in the previous slides, these percentages represent a significant chunk of money for both the insurers and for the patients that they are covering. You go to the next slide. So looking at total spending and total rebates, the rebates for specialty drugs, as we just saw, rose about 41% between 2017 and 2019. Though the cost of spending on specialty drugs only rose 24%. This is something that Callie and Lila will be talking about later, is just this discrepancy between the increases in total spending and the increases in rebates associated with that spending. Can we go to the next slide, please? So today we're here really to talk about how Colorado is going to be thinking through what we do about prescription drugs and the affordability for Coloradans. This is something that is of interest across the country. So in order to help support that board, CIVHC was called on both by the state and at the behest of the payers to supply some data to help support this organization or this board. We did need to create a new file that would enable us to collect certain data required in the bill that we didn't previously collect. The rule hearing to finalize that was on February 4th, and that new file type will be submitted starting in September of this year, and will include a 3-year look back on the information that we're collecting. So we have typically only collected aggregate drug rebate data at the drug type level, so generic, brand, and specialty, reflecting what we've been showing in the graphs up till now. We haven't received any information on specific individual drugs. So what kind of rebates, which are the 5 or 15 top drugs we're actually seeing tied to high rebates, and how high are they? This new data collection will allow us to actually start looking at which of the drugs is really driving some of these trends and moving us further along this increased cost road. Next slide. So some of the required elements are already in the APCD. We do have a very supportive relationship with our payers, and much of the data that the Prescription Drug Affordability Board is going to be looking at is already part of the APCD, and all we have to do is package it to be able to support their analyses. The 4 elements that we're going to have to collect in addition are the top 15 prescription drugs that cause the greatest increases in the payer's premium, is 1. 2, that the payer paid for most frequently and for which the payer received a rebate from manufacturers. So which are the most common drugs that they paid for that also had a rebate. The third one is the top 15 drugs that had the highest rebate by percentage of the price of the prescription drug. And then the fourth one is the 15 prescription drugs where the payer received the largest rebates in dollars for the prescription drugs. So now that we've sort of talked a little bit about the prescription drug landscape in Colorado and a little bit about how Civic is going to be supporting the PDAB bill, I am going to hand this over to Lila and Callie, and they can talk in a little bit more detail from the DOI side.
Kristin, thank you. Before I jump to you, hang on just a second. We have a couple questions that I think we probably should address. One is whether the drug rebates that we are collecting include the use of consumer copay accumulator program.
Some do. Some do. I don't actually have much more detail on that than what we've talked to, but some do. It's not.
And then another quick question then, if the rebates have to be counted as part of a commercial carrier's MLR.
You know, I don't actually know the answer to that question, but I can certainly look into it. I don't know if they are or are not counted as part of the MLR. The MLR is the medical loss ratio. And so I'm not sure if they do or not. We can look into that and hopefully get back to folks. But I don't know the answer off the top of my head.
I think when we've talked to the carriers before about that they say that they do count them. And I think that they are supposed to consider drug rebates in the MLR. I think that that's a good question. All right. Well, thank you, Kristin. And Lila, I will turn it over to you.
Great. Thank you so much, and thank you for inviting me. And Kristin, that was a lot of really good information. So thanks for it was kind of new to me. So thank you for that. So like Carrie said, my name is Lila Cummings. I am the Prescription Drug Affordability Director with the Division of Insurance, and joined today by my colleague, Callie Shelton, who is the Prescription Drug Affordability Policy Analyst. So we're going to walk you through kind of some high level kind of just background on what the board is. We'll provide some information on the advisory council, then dive into some more specifics on the types of data that the board might be using in kind of a couple of different buckets, both transparency reporting, affordability reviews, and upper payment limits, and then move on to questions. Okay, next slide, thank you. All right, so the Prescription Drug Affordability Board, PDAB, brand new acronym, nothing like it, just piling on acronyms in the healthcare space. But so this board was created along with the Prescription Drug Affordability Advisory Council, or PDAC, by Senate Bill 21-175. The PDAB is a 5-member board, and the requirements for board members were that they needed to have experience and/or expertise in clinical medicine or healthcare economics. The board is a Type 1 board with rulemaking authority. It lives within the Division of Insurance, and currently the board is meeting every 6 weeks. We can go to, great. And so the 5 members that were appointed by the governor on September 27th include Dr. Gail Misner. She is the chair of PDAB from Snowmass, Dr. Sammy Diab from Greenwood Village, Dr. Amy Gutierrez from Aurora, Miss Kathy Harshbarger from Holyoke out on the Eastern Plains, and Dr. Vandenberg from Denver. And so they're kind of associated with a number of hospitals and federally qualified health centers across the state. So the board, this is very, very high level, but this kind of outlines their main responsibilities. So the board has a responsibility to collect and evaluate data on the cost of prescription drugs for Colorado consumers, perform affordability reviews when a drug meets certain triggers outlined in statute. The board may then set an upper payment limit on drugs the board has deemed unaffordable. And in a little bit, we'll talk about kind of what these processes might look like. And I will note that there's a maximum, the board may not set an upper payment limit for more than 12 drugs per year for the first 3 years of the program. The board also has a responsibility to make policy recommendations to the legislature. And beginning in July of 2023, the board must report annually to the governor and legislature about drug prices, board activity, and impacts on providers and pharmacies. Great, and I'll turn it over to Callie.
Thanks, Lila. So in December, the board appointed the Prescription Drug Affordability Advisory Council. It's a mouthful, so we're using the acronym PDAC. And the PDAC is composed of 15 stakeholders with a diverse array of perspectives related to the work of the PDAB. They are a Type 2 board that meets at least quarterly, but they are statutorily allowed to meet privately in groups of 3 or fewer to gather data or plan for council business as long as no formal action is taken. Next slide. Thanks. And so, like I said, the PDAC consists of 15 members representing different stakeholder groups. Statute does require that one member be the executive director of HCPUF or their designee. But the other folks were appointed by the board to represent different interests, including consumers. And there are 2 consumers on the council, consumer advisory advocacy organizations, consumers with chronic diseases, labor unions, employers, carriers, PBMs, prescribers, researchers, manufacturers of both brand and generic drugs, as well as pharmacists and wholesalers. And I won't read all the names of these lovely folks, but they are all listed on our public website for your reference. I also did want to mention that the statute requires 1 council member be from the Eastern Plains, 1 from the Western Slope, and the board also attempted to appoint members from each congressional district. And so this slide here is just for us to show off how smart and qualified our council members are. So among them, they have expertise in the pharmaceutical business model, the supply chain, medical practice or clinical training, consumer and patient perspectives, drivers of healthcare costs, clinical and health services research, as well as the state's healthcare marketplace. And next slide. Thank you. And so the council members will take all of that collective experience and knowledge and provide recommendations, information, and analysis to help the board make informed decisions. And the 2 major roles for the PDAC, which are outlined in statute, are to provide stakeholder input for the board regarding prescription drug affordability and to provide input regarding specific drugs when the board is selecting a drug for affordability review. And lastly, I did want to mention that our first PDAC meeting is tomorrow morning at 9 a.m. And if you're interested in joining that, you can register for that meeting at the PDAB website, which I'm more than happy to put in the chat. So I'll hand it back over to you, Lila.
Great, thanks, Callie. And I will say too, I just looked at the attendee list, and I know we have a number of our advisory council members have joined today. So that's great, and we're very much looking forward to kind of the expertise that the advisory council will bring to this work. Okay, so now we'll kind of take a step back and walk through kind of what we anticipate some of the data needs will be for the board, and we can go to the next slide. And we'll walk kind of through the high level needs, but I want to emphasize, oh yeah, we will put the meeting info in the chat. I do want to emphasize that this work is just beginning. So the board has met 3 times, and they have promulgated a few rules, but really this work is just starting. So there's not a lot of data that we have to show yet, right? The work is beginning, but I will say that over the next few months, the board has a lot ahead of them that they need to accomplish and that they will be accomplishing. So we highly encourage folks to reach out to us if you have questions, and to stay kind of closely aware of the work that's going on, because a lot will probably be happening over the coming months. So there are 3 main areas that have potential data needs in the statute that created the Affordability Board. The first is carrier and PBM transparency reporting. And then there is some work very specific to the board itself. So this includes the affordability review processes that the board will need to create, as well as the upper payment limit processes. So we'll talk about that in a little more detail in a couple minutes. So next slide. Great. But so talking about the transparency reporting. So in statute, and Kristin already kind of spoke to this a bit, so I won't spend too much time on these slides. But statute did outline that beginning this year, each carrier and pharmacy benefit management firm acting on behalf of a carrier must report certain information to the APCD. This is for all prescription drugs dispensed at a pharmacy in Colorado and paid for by a carrier. This includes brand name drugs, authorized generic drugs, biological products, and biosimilars. And really, we're thinking about this transparency report in really 2 buckets. There's some new, or I guess repackaged reporting on top 15 prescription drugs, and then some other reporting regarding total spending. So we can go to the next slide. Okay, and so in terms of the top 15, this is kind of reiterating some of what Kristin said earlier, but there's certain drugs or certain categories where carriers and PBMs must report the top 15 prescription drugs across these 7 categories. So they need to report the top 15 prescription drugs by volume, the top 15 costliest drugs determined by total annual spend, the top 15 drugs that accounted for the highest increase in total plan spend, and then the bottom squares here are the ones that Kristin mentioned. These are the kind of new reporting. So that caused the greatest increase in premiums, the top 15 drugs that a carrier paid most frequently and received a rebate, top 15 that the carrier received the highest rebates for, and the carrier received the largest rebates for. And we can go to the next slide. And then, so this is, again, information that may have already been submitted, but not necessarily packaged in kind of this prescription drug affordability way. But so carriers and PBMs must also report total spending across 8 categories. So you'll see here the total spend for brand name drugs purchased from retail pharmacies, and then as well as mail order pharmacies, authorized generic drugs at retail pharmacies and mail order pharmacies, then the total spend for drugs dispensed by a practitioner, total spend for drugs administered in an inpatient hospital setting, and total spend for drugs administered at an outpatient hospital setting. And then the last, kind of the 8th category, is total spend across all of these categories. Okay, next slide. Okay, so now we'll kind of take, so that the past few slides were really what will be reported to CIVHC beginning this year, and that was the kind of rulemaking that Kristin just outlined. Now we'll shift into kind of some more direct work that the PDAB itself is doing. So I will say this board is in a unique position as the inaugural Prescription Drug Affordability Board. So we really like to think of this board as wearing 2 distinct hats that future boards in years to come won't necessarily be wearing. So the first hat is this procedural hat. And so this board has a number of duties to promulgate rules to establish the methodologies and processes that will be used kind of moving forward. The board also is establishing policies and norms, and those are some of those policies are available on the PDAB website. This includes kind of some of the run-of-the-mill housekeeping policies, but also things like their conflict of interest policy. So some of those kind of pretty important policies that need to be established. They're also kind of responsible, along with the advisory council, for figuring out, what is in statute and then what is best practice for how the board and the advisory council work together. And then the board also has this kind of substantive hat. And so that is kind of, we talked about this a little bit already. This is their statutory duties. So once they establish the processes for prescription drug affordability work, then they'll actually do the process. So this is collecting and evaluating data, conducting affordability review work, conducting upper payment limit work, making policy recommendations, engaging with stakeholders in the advisory council, and monitoring and revising their policies as needed. We can go to the next slide. Great. So this is, I'll walk through this and happy to pause and answer questions if needed. This is the highest level overview of what the Prescription Drug Affordability Board needs to do. This process map, I will say, is not exhaustive. And I will note that for each of these buckets, for each of these squares, there are some areas where the board is required to promulgate rules to establish certain methodologies, and other areas where they're not required to, but they may choose to put a methodology in rule, or they may choose to create kind of sub-regulatory policy guidance that outlines, how each of these buckets is completed. But so at the highest level, you'll see this first row is kind of this first bucket of work around an affordability review. So in the affordability review space, there's a number of steps. The first is for the board to identify drugs for an affordability review. We'll talk in a couple slides about what that means. Next up is, from that identified list, the drug must select drugs for an affordability review. Then the board will conduct an affordability review. And then at the conclusion of that, they will determine if a drug is unaffordable. So that's kind of that affordability review bucket of work. Then next up, the board would establish an upper payment limit, notify consumers of the decision to establish an upper payment limit, inquire whether manufacturers intend to make the drug available in Colorado. Then the upper payment limit effective date would begin, and then payments for that specified drug would not be able to exceed the upper payment limit, with the resulting consumers being able to access the drugs at a lower cost. So I'll kind of point out here, the establish upper payment limit bucket. That is one where the board is required to put that methodology for an upper payment limit in rule. And so that rulemaking will be taking place kind of in the coming months. So, okay, next bucket. We'll dive into each of those a little bit more in terms of the data that is either statutorily required or that we anticipate the board might want. So in the first step of identifying drugs, there are certain prescription drugs, and it depends on really it hinges on the drug's wholesale acquisition costs. And so the information that you see on this slide is pulled straight from statute. So this was outlined in statute. These are the criteria that can kind of signal that a drug is a potential drug for which an affordability review could be conducted. So there's three main buckets. There's brand name drugs or biological products. And for those, there's two categories. So for brand name drugs or biological products with an initial wholesale acquisition cost greater than $30,000 for a 12-month supply or for a course of treatment, or brand name drugs or biological products with an increase in wholesale acquisition costs of greater than 10% in the preceding 12 months of course of treatment. The next bucket is biosimilar products. Here, drugs that might be selected for an affordability review are ones with an initial wholesale acquisition cost that's not at least 15% lower than its corresponding biological product. There's probably a simpler way to phrase that, but it's a biosimilar product that's not at least 15% lower than its corresponding biological product. And then last but not least are generic drugs. So the generic drugs that might be selected for an affordability review must have an increase in wholesale acquisition costs of 200% during the preceding 12 months and a wholesale acquisition cost of greater than $100 for either a 30-day supply, a supply that lasts less than 30 days, or one dose of the generic drug if the FDA does not recommend a finite dose. So those are the broad categories of drugs that might be identified for affordability review. So the next thing that the board will need to do is select. So of this large list of drugs that might qualify for an affordability review, the board will need to select which drugs to send through the affordability review process. In statute, there are 4 kind of criteria that the board must use when selecting these drugs. So the board must evaluate the class of the drug and whether there are therapeutically equivalent drugs for sale. The board must evaluate aggregated data. The board must seek and consider input from the advisory council about the prescription drugs it is considering putting through an affordability review. And last but not least, the board must consider the average patient's out-of-pocket cost for the drug. I'll pause here and note that this is where we really are looking for kind of thorough stakeholder engagement as this process unfolds. You'll notice evaluate aggregated data is a pretty broad term, and I think it was intentionally put in statute to really allow the board to say, okay, when we're starting from this large list of identified drugs, what criteria should we use to determine which drugs should actually have an affordability review conducted? And evaluating aggregated data is a pretty broad term that will allow the board to kind of find the right criteria for selecting drugs for an affordability review. And it is absolutely something that we want advisory council expertise on. The board has signaled they want stakeholder expertise on of what sort of aggregated data should the board evaluate in this kind of selection process. Okay, we can go to the next slide. Great. So then comes time for the actual affordability review. So in statute, there are a number of things that statute outlines that must be done in the affordability review. The affordability review shall consider the current wholesale acquisition costs for the drugs that might be selected, the cost and availability of therapeutic alternatives, the effect of price on a Colorado consumer's access to the drug, the financial effects of on health, medical, and social concerns, patient copay and cost sharing, the impact of the drug on safety net providers, and also the drug's orphan drug status. But in addition to kind of these more kind of data-driven conversations and considerations, the board must also consider input from patients and caregivers, and individuals with relevant scientific or medical training. And then the board may also consider any other information that a manufacturer, a carrier, a PBM, or another entity chooses to provide in this affordability in the affordability review process. And I will say too, these are outlined in statute, kind of the laundry list I just read. If the board chooses to add any other criteria that it wants to consider when conducting an affordability review, that will need to go in rule. And we kind of anticipate that the board will in some way, shape, or form want to fashion either sub-regulatory guidance or rules that outline how the affordability review is conducted in greater detail. So. Okay, so then moving on from the affordability review. So then at the conclusion of the affordability review, a drug may be deemed to be unaffordable. Again, the exact how of how all that data will inform whether a drug is unaffordable. The board is in the process of creating that methodology now. So we don't yet know, kind of what will exactly trigger a drug being deemed unaffordable. That's methodology that they're developing over the next few months. But so for drugs that may be deemed unaffordable, the board may then choose to set an upper payment limit for those drugs. This methodology will need to be established and spelled out in greater detail in rule. And statute kind of outlines a couple things that the board must consider when establishing an upper payment limit methodology, and then some things that the board may not consider when establishing a UPL or upper payment limit. So the board must consider the administration and dispensing fees for the prescription drug that is chosen for an upper payment limit, the cost of distributing the drug to Colorado consumers, the status of the drug on the FDA's drug shortage list, and other relevant costs associated with the drug. The drug must also, or the board must also consider when establishing a UPL, the impact to older adults and people with disabilities. One thing that is important to note, and will be, I think, a topic of pretty good, robust conversation between experts in the comparative effectiveness world, the board and advisory council members, is that the upper payment limit methodology may not consider research or methods that employ a dollars per quality adjusted life year, or QALY, or similar measure that discounts the value of life because of an individual's disability or age. So any sort of comparative effectiveness that is considered when setting an upper payment limit cannot be one that employs QALYs. Okay, and so that was at the highest level a lot of the work. I think over the coming months, the board will be taking feedback and establishing these methodologies. And so this time next year, we'll have a lot more detail, but at the highest level, that is kind of what the board and the advisory council are working on over the next few months.
Thank you, Lila and Callie. Such great information, and so exciting to see this coming to fruition, and very exciting you're having your first meeting tomorrow. Very cool. Thanks for adding that in the chat for folks who want to attend. We did have a question, and feel free if you have questions for either Kristin or our friends at DOI, please let us know in the chat box. I know we did have one question when you were talking about the reporting requirements. There's a question regarding what's the difference between highest rebates and largest rebates.
Yeah, I'll take a stab, and then Kristin, correct me if I'm wrong. So the highest rebates would be total, the largest amount received for a single drug. The largest rebates would essentially allow for it. The rebate amount itself might be smaller per dose, but in totality, because say it's a high utilization, that it's the largest rebate. But Kristin, correct me if I'm wrong there.
That might be something we have to figure out, because I thought it was the highest rebates by percentage. So what's the percent of the rebate? So if the rebate is 27% or 37%, what's the highest rebate percentage, and largest was largest number of dollars.
Okay.
So
and actually, Kristin, I think that might be right. I was that's a good point. I think I was thinking of one of the total spend metrics, not the rebate metrics.
Okay.
All right, I don't see any other questions in the chat. I actually have a question for you, Lila. Are you guys going to be reporting publicly the drugs that you're evaluating, so that like larger list? Is that something that's going to be publicly available, or will it only be when you get to the point of like the shorter list that's going to be more thoroughly reviewed?
That is a great question. I do not think the board has considered that yet. I think as it stands, the current thought would be that it's all public, right? That there's a number of things that might not be made public, but really that has to do if the manufacturer, wholesale or carrier or PBM discloses any sort of proprietary data. At this point, that is the only thing that we think would not be made public. I think we anticipate that that initial list would be completely public.
That's great. And then just curious, maybe you haven't thought through this either since you guys are just getting started, but are you going to do any evaluation like after those upper payment limits have been established of what the actual cost savings is to Coloradans?
Absolutely. And there is actually a requirement in statute that we're working on, or we'll be working on promulgating rules in the summer and fall. Carriers and PBMs will be required to report how they have used any savings as a result of an upper payment limit. And then beginning in 2023, the board will need to kind of in a report prepare further information on impacts of the upper payment limit, including utilization and kind of maybe other metrics there.
That's great. And then there's a question if you can post the link where the meeting information that you guys are holding, like I'm sure you'll have slides and maybe even recordings where that will live. It might be the same link that you added earlier, Callie, but if you don't mind adding that, that would be awesome.
Great. That's
Great.
and I will say too, so Callie just linked to our website. And so I'd encourage folks to visit that and encourage folks to sign up for, we have a PDAB specific listserv where our goal is to announce meetings at least 2 weeks in advance. And we always try and get the materials on the website for these meetings a week in advance. And yes, to the question about Sunshine Law, yes, all of these meetings will be open to the public. The only meetings that might not be are really outlined in statute that allows advisory council members to gather in groups of 3 or more, or 3 or fewer folks, but really to just discuss. There's a very specific number of items that can be discussed, but we anticipate that would be the only time that there would be a smaller meeting that's not open to the public. Otherwise, everything will be open to the public and published on our website in advance.
Great. And Nathan jumped in with the definition. He looked it up with largest rebate equals
great.
the total rebate amount, dollars. Highest rebate is the highest percentage discount from the original drug price.
Thank you.
Thank you, Nathan.
Yeah, and Nathan's one of our advisory council members, so I'm great. It's great to know how resourceful he is.
He's also the chair of our All Payer Claims Database Advisory Committee, so he is a wealth of knowledge to all of us. Thank you, Nathan. And Tom Rennell also typed in, who is subject to the UPL? Is that pharmaceutical companies or hospitals or other providers? Good question.
That is a great question. So it is not manufacturers, right? So the upper payment limit will be for the individual who buys the drug. I will say that the statute is actually pretty vague. And so that is something that we anticipate in terms of the question of hospitals or other providers or the individual. We do anticipate kind of making sure that that is clarified of who is subject to the UPL in rule kind of over the course of the summer. But I will say that we do know that it is to the person who purchases the drug, not the person who is selling the drug.
Okay. And then a question from Deb Parsons, what does the cooperation and the resistance look like from the various stakeholders involved in the process?
That's a great question. I think we're not quite sure yet. I will say, that I came into this work after the legislative session. I do know that it was pretty kind of there was a lot of negotiating that happened during the legislative session. And I think that's one of the reasons why the advisory council was created, right? We want these diverse perspectives. And we do know that there may be points where folks, at the end of the day, they don't agree. But we want the advisory council's purpose is to create that forum to really understand why folks might not agree and dive into the expertise that folks have on why they don't agree, what they think might be a better solution, or what their concerns are and what unintended consequences are. So we'll more to come as the process unfolds.
I don't see any other questions. And this is another slide that you guys wanted to make sure folks were aware of all of the resources. I think we've talked about a lot of this already. But there's also information on questions and links. So again, this will be a slide that you can see in the recording. We'll have the actual slide deck saved for you guys to reference this as well if you don't have time to jot it down now. And then I think that we will go ahead and just remind people that our next webinar, we have a little shift in timing. We usually do these the third Thursday of every month, but we had a little bit of an issue with spring break coming up in March with our next presenter. So we are going to be hosting Janssen Scientific, and they're going to be talking about the study that they did using COA-PCD data that investigates the impact of insurance churn on young adults with schizophrenia. So a very specific, very different topic that we'll be featuring next month. And just note that that's March 31st instead of the third Thursday of the month. So we're excited about that. And look, you'll be seeing more information about the registration on that in the weeks to come. So Thank you again for everybody joining us, and thank you to Kristin, Callie, and Lila for excellent information that you shared. We look forward to tracking the progress of the PDAB and the PDAC, which that was a new acronym for me it just rolls right off your tongue. So I'm excited to have another one in the healthcare alphabet soup. Fantastic. So thanks, and have a great rest of your day, everybody. We appreciate you being here, and thanks again to our presenters. Take care.